Great. Thank you so much for those presentations. My name is Suzanne Maman, and I'm the UNC Faculty Director for this fellowship program. And I'll just say a few words on behalf of my colleagues at UNC. We are so invested in this program, not just because of the opportunity we have to train these fabulous fellows to see their work beyond our training programs, but because of what they bring to our other students at UNC. You can see from their presentations, their backgrounds enrich the conversations in our classroom in so many important ways. So it's really a privilege to be part of this fellowship program. So through this panel on community health as a building block towards more peaceful societies, we heard from two fellows who used their background and training in clinical medicine and public health to explore the critical role of health in peace building. And there are so many ways that peace building can be fostered through improving access to healthcare. Improving health outcomes can address some of the underlying causes of conflict, such as poverty and inequality. Healthcare programs can empower communities by providing them with knowledge and resources to take control of their own health outcomes. Investing in healthcare infrastructure and systems can help strengthen institutions at the national and local levels. Addressing health challenges can mitigate the risk of further instability. And finally, health populations are better able to participate in and contribute to the economic growth of their societies. So Estefania examined the role of health insurance in providing the Latino community in the US access to health care, while Alexis was involved in a pilot study that engaged community health workers as agents of peace to support HIV-infected women who are experiencing intimate partner violence in South Africa. At the root of both of their presentations is the belief that health and healthcare workers are central to the support and security of populations affected by conflict and instability. So I'm going to ask a couple of questions for our panelists, and then we'll open it up to our residential and online audience. And I'm going to start with a question for Estefania. Given the focus on Medicaid expansion in North Carolina as a means to reduce health disparities, what are the key obstacles to Medicaid enrollment among Latinos that you've identified? And the second part is, what policy recommendations would you make to streamline the process and make it more accessible to this population?
Thank you for your question, Suzanne. So the main obstacle that we have found are that people don't even know that there is this like expansion happening and that they are able to access Medicaid. Sometimes they don't even know what is healthcare, what is a healthcare system. So it's lack of awareness, lack of understanding, and a lot of literacy issues. And so, yeah, those are the main barriers. And yeah, for these, like the policy recommendations will be to do more materials that are, you know, like bring materials through social media that are easily digestible and culturally competent, and this way the community, Latino community, can understand and be aware of accessing the system.
Thank you. Now for Alexis, we know that in the overcrowded and understaffed clinics like the ones you worked in Johannesburg, community health workers are already very busy. They have many responsibilities in the clinic. So yet your project demonstrated the critical role they can play in addressing an important determinant of women's health, which is gender-based violence. How can we really expect health workers, community health workers, to add this to their workload, especially without additional compensation?
Thank you for your question. I had the opportunity to discuss this topic with all the community health workers. And one of the recommendations they asked was to train more of them. Only some were trained, which is not enough. And about the payment, something we should know is South Africa has a different system. I mean, in South Africa, community health workers are paid. It's not enough, but they get something. But in other systems, like in Congo, community health workers are not paid. So at the beginning, community health workers, those are fantastic people. So they accept to work for no payment. They accept, they like, we can do it, it's for our community. So they're grateful for the little money they're getting, but to go back to your question, as long as we can train more of them, they will find a way to manage, to do their work in the clinic, and to take care of victim of gender-based violence and more.
I'll turn it back to you, Estefania. Another question. Given the focus on Medicaid expansion in North Carolina as a means to reduce health disparities, what are the key obstacles to enrollment among Latinos that you've identified?
Yeah, so the main obstacles are that sometimes people actually show up to the office, like the government office, to enroll, and they face a lot of discrimination. So that is like the first approach for them, like with like a government institution in some cases. So they come and they bring documents and stuff, and the community health workers like already have told the potential enrollees that are at the office that you need to bring this and that, but like their job is already done. Like they cannot like come with them to like an appointment and like do the whole process. So they face discrimination. Sometimes we've heard from the Latino community that they get asked questions that had nothing to do with Medicaid, like I don't know, like, what are you doing here? You need this extra document that is not on the list, and they have to like come back and forth. And then there's another question, you miss this, you miss that, or like, why is there so many people living in your household and stuff like that? And so the community listens to this, and they like feel rejected, and they don't want to come back, or like they don't know what to do about it. So they go back to the community health worker, and like there is no actually good strategies to like manage that. So sometimes the community health workers do that extra effort of like, you know, coming with the person that wants to enroll and like do the process together with them, but that like that is not possible, like in terms of capacity. So it's that they approach the system and they feel that rejection and they don't come back.
And so the second piece of that is at the policy level, what can we do to overcome some of those barriers that they're facing?
Yeah, I think at the policy level, I think we are able, or the people that are trying to enroll can be able to track if they had like some bad type of treatment and like report that, or like keep track of what are their rights and what aren't, and just maybe have like, you know, some sort of digestible information of like what is good to ask, what is not good to ask, like what document do you really need, and how to like, you know, be aware of your rights and mention that when you are at the Medicaid enrollment office. And I think that could also be part of the community health workers' duty of like communicate with them and tell them, okay, there is this manual and it is like easy to read, and like if you have more questions, like we can figure out something later, but like to be able to explain them like they have a right to access the system. So I think, I mean, it is policy, but also like part of relationship building and community engagement.
One more question for Alexis before we open it up. How do you ensure the safety and confidentiality of women seeking support from community health workers in situations of intimate partner violence, especially in contexts where reporting or seeking health might pose additional risk to the women?
That's a big challenge for safety and privacy. What I've seen in those two clinics is, let me take one clear example. When I was talking with community health workers, One day we used the parking lot because there were no space in the clinic. So trained community health worker, what they do to keep confidentiality and privacy, they have to do their best, find a place. But still, it's a big challenge. As I said in my presentation, gender-based violence is not a priority in the clinics because clinics are first taking care of had health issue, like someone who comes for headache or stomach ache. They will take that person first than the one who comes for gender-based violence. So finding a space is a real challenge. So the way community health workers are trained, they need, before starting to talk about that sensitive topic, they need to find a place which is really private, even though it's a parking lot or it's sitting in a car somewhere around the clinic, but they need to find that space, talk about it. But it's a big challenge that has to be addressed by the South African government because it's the only one who can provide more space for privacy and confidentiality.
Thank you. Okay, we'll open it up for questions from the audience. And I see a couple right here in the front.
Can you raise your hand that I can see? Down there, then you can do it, Ola.
Thank you. Good morning. Both of your presentations were wonderful, and it's nice to see you again, Professor Maman. My question is, I think Alexis briefly touched upon this, but were there any challenges or hesitations in recruiting the community health workers? And were there any challenges that the community health workers face from the community, such as culture or stigma on the topic?
So one good thing with the community health workers, I said it at the beginning, community health workers first are members of the community. Those guys are trusted in the community. That makes their job a little bit easier. But when it comes to gender-based violence, it's something else. You know, for a woman to open up to someone else about gender-based violence, as you know, in Africa, it's almost a taboo for a woman to talk about what's going on in her household. But the way community health workers are trained, they know if they see that there are some signs of violence, they know how to approach women, how to talk to them. But it's not easy. It's not the first time. I mean, it's not at the first contact that the woman will talk. Maybe the community health worker has to come back 3, 4, or 6 times until the woman will feel like, okay, I can talk about it. But still, it's a big challenge to make people talk. And I said it, the more women are trusting those community health workers, the more they feel like they can have solution to the issue, the more they're talking. So how things work back there, if a woman went and talked, then once she's back in the community, she will tell her friend that I went there and I got a solution. There is someone who listened to me and gave me a solution. And that's how they like breaking all those barriers. But it's a big challenge.
Take a question from if there are any from the online audience.
This is for Alexis. You talk about education and changing perceptions, but what about the law? And if the law is not upholding or penalizing people for gender-based violence, how would you address that, or what suggestions would you make to make the changes there?
So I wrote that in my master paper. I'm writing about gender-based violence. So the South African government is passing some law to protect women. And as you know, the thing with law, it takes too long for it to be like really in practice. But South African government is working on passing some law that can protect all abused women. also men, because some men are also abused, as you know.
We have time for one more question, and I see two, so sorry, go here, and hopefully you'll find time at lunch break for that.
What do you both feel or think about the role of corporate interests in promoting public policy?
I will let Estefania, because she's the policy person.
Yeah, so thank you for your question. So it is not like a topic like we deep dive in, but we know that there's like a lot of influence and that like a lot of the things that community health workers know and say are because of some training that they have gotten from the private insurance system. But like at the same time as in the US, there's a mixed system. They also have to be part of it at some point. So sometimes there are like some plans that are like linked to Medicaid, but are also private. And so they have to know that to tell people what's the better plan for them. So there's like a big influence on that side. And there's like, I don't know, how to say, like a best practice to do that. They just have to look at the options and tell people what is more affordable for them in that moment, like given their job or whatever situation they are in.
I'm not a law person, but I think, as I said, South Africa is already working on that. But the thing is, I'm going to talk in an African perspective, which is different here. It's nice to have laws, but it's better to apply those laws. We have many laws, but we are not applying them.
I think I had a cue that we have time for one more short question. So I did see a hand raised here. Let's go back, right here. Yeah.
Thank you. I wanted to ask Estefania, I know that your research has been focused on people who are documented, but we also know that there's a large population of undocumented people in North Carolina in particular. And we also know that Medicaid, even if everyone applied, wouldn't cover everyone. There are people who are going to not be eligible. Is any of your work being done on individuals who are undocumented, who also deserve health care?
Sorry, can you repeat the last part?
Is any of your work being focused on individuals in North Carolina who are not documented?
Oh yeah, so yeah, sadly we cannot do much about it, but there's like a pilot system where there are like clinics where people can go and get treatment. But I mean, in the case of Medicaid, I think the only way they can access is if they have like some very, very critical condition or they're like an emergency, like when it happened during COVID, but there is just like no way at the moment to like break that barrier. And even if we look at the census data and all of that, we are not able to gather information about people who live undocumented. So that's a big issue.
All right. Well, I wanted to thank our panelists, and we will close this session. Thank you so much for participating.
So we are going to break for coffee right now. And if I could ask everyone to aim to be back in the auditorium no later than 11:05. Enjoy your break.